We are live.
All right. Good morning, everyone, and welcome to our June GIC Commissioners meeting. It's lovely to see so many friendly faces. Welcome to those who are watching on YouTube, and thanks to everyone for joining. I'm Valerie Sullivan, I'm chair, and I'm going to turn it over to Andrew, our general counsel, to introduce and highlight our commissioners who are on our board who are here today. So go ahead, Andrew. Hello.
Thank you, Chair. People are joining as we speak, so if I miss anyone, please let me know. Currently, joining us this morning is Rebecca Butler, our designee from the Commissioner of Insurance, Tamara Davis, Commissioner Jane Edmonds, Commissioner Joseph Gentile, Commissioner Trezino Garon, Commissioner Eileen McEnany, Commissioner Melissa Murphy Rodriguez, Commissioner Jason Silva, Commissioner Anna Sinenko, Commissioner Timothy Sullivan.
All right. Thanks, Andrew, and thanks for everyone who joined. We may have others joining, but we started right at 8:30 and we were at quorum. So we'll announce any commissioners who join after.
The Vice Chair, Bobby Kaplan, has joined.
Oh, hello, Bobby. Thanks for joining.
Morning.
Yes. All right. At this time, I'm going to turn it over to Matt, who's going to review our very busy agenda for today.
Thank you, Madam Chair. Welcome, commissioners. Thank you for joining us, and those on my staff who have joined and those following along on YouTube. As has been noted, we have a full agenda for this, our last meeting of the fiscal year. We are pleased to welcome Lauren Peters, which I will do in a moment, the Executive Director for the Center for Health Information and Analysis, also known as CHIA. Executive Director Peters is here to present on the Commonwealth's prescription drug use and spending from CHIA's latest analysis that was released earlier this month. So excited to kick this meeting off with Lauren Peters. Then Director of Operations Paul Murphy and Communications Director Leslie Montero will present a report out of our recently concluded 2024 annual enrollment. And next, we will have Director of Vendor Management Cameron McBean, who will present on the GIC's recommendation for a consultant for the dental and vision procurement. That will be a vote for the commission. And we will close with Jim Rust, our CFO, with his CFO report. So with that, Madam Chair, happy to hand it back to you for the minutes.
All right. Thanks, Matt. I always love getting an update from CHIA on all the data that's out there. So I'm really excited about this upcoming presentation. I've been told that Toby Choate has joined, one of our commissioners. I don't see you on camera yet, Toby. Oh, there you are. Hi, Toby. So let's note that in the minute. And at this point, I will entertain a motion for our minutes from our May meeting. So I've had a chance to review them, and I say aye. Andrew, do your thing. Let's get a vote. Oh, first, do I need a motion? I need a motion to approve.
Moved.
So moved by Bobby. Second?
Second.
Second by Rebecca. So at this point, I'm a aye. And Andrew, if you can do that, that would be great.
Thank you, Madam Chair. Vice Chair Kaplan?
Aye.
Has Commissioner Designee Sullivan joined? Don't think so. Designee Butler?
Aye.
Commissioner Choate?
Aye.
Commissioner Davis?
Aye.
Commissioner Edmonds?
Aye.
Commissioner Gentile?
Aye.
Commissioner Garon? Trezino?
He might be on mute. Let's move on.
Commissioner McEnany,
Aye.
Commissioner Murphy Rodriguez,
Aye.
Commissioner Silva,
Yes.
Commissioner Stanenko,
Aye.
and Commissioner Sullivan.
Yes.
The motion passes unanimously of those voting.
All right, thanks, Andrew. So at this point, I know we're turning it over to our next topic. Matt, do you want to ask for, let's go over the executive director's report. It was pretty meaty this month. So Matt, take it away.
Yep. Thank you, Madam Chair. In the interest of time, I'll keep today's update brief and encourage commissioners to review the written report and reach out to us with any questions. On the HR front, we are happy to welcome Eileen Pena to the Medicare Enrollment Unit, the Operations Department. I had an opportunity to meet with her upon her arrival. Happy to have her join the team at a busy time. The written report also contains a brief summary of 2 healthcare bills that are currently pending before the legislature. We continue to track both bills closely and are in consultation with our colleagues in state government about impacts. I have also provided an in-depth update on the new hire reduced waiting period project, which has been ongoing and a lot of work for our team. We are on track to go live on July 1st with the changes here. Commissioners also received in your meeting packet the administrative bulletin that you voted on in the last meeting, which we released in conjunction with these changes to provide offline and municipal entities information about these changes. So a lot in that report. Happy to take any questions before we move on.
I don't see any. All right, let's move. Thanks, Matt.
Great. So quick look at the calendar, which will also be brief since today's meeting is the last of our current fiscal year. As we do every year, we'll take a brief break from commission meetings in July and August and come back together as we start things off in September. While we do not yet have a projected agenda for the fall, we are already pulling together an outline of a presentation to follow up on issues raised in the May meeting about prescription drug trends and the steps that we take through CVS to manage utilization. So I wanted you to be aware that we noted the interest in that topic and want to make sure that we come back to you with a thoughtful and thorough presentation to put all of that into context. With that, however, the timing worked out very well here to have the next presentation. So it's my pleasure to introduce Lauren Peters, Executive Director of the Center for Health Information and Analysis, CHIA. As this commission is well aware, CHIA is an independent state agency charged with reporting information and data about really important dynamics in the healthcare system: affordability, utilization, access, outcomes. They're doing some excellent work around primary care and the state of the primary care system, as well as what you will hear today about prescription drugs. Executive Director Peters has extensive background in government, leading on complex healthcare issues. She's spent time in the legislature, at the Health Policy Commission, the Executive Office of Administration and Finance, and Executive Office of Health and Human Services as Undersecretary. And we are really fortunate to have her here today and have her leading one of the really key sister agencies at CHIA. And as this commission is well aware, CHIA's role really is to provide a data foundation for our understanding about these important trends. And today we look forward to hearing from her about the most recent publication on prescription drugs. Lauren, thank you so much for joining us. Welcome. I know you're joined by a member of your team who had asked you also to introduce to the commission.
Great. Thank you, Director Vino, and good morning, commissioners. It's great to be with you and see so many familiar faces. It's been a while since I've attended one of these Thursday morning meetings. And I'm joined today by my colleague Molly Bailey, who's an associate manager on our health informatics and reporting team. So we appreciate the opportunity to present findings from our most recent drug spending and utilization report. Next slide, please. I won't spend too much time on background because I think Director Vino did a nice job sort of teeing up and providing an overview of CHIA and its role. If you wouldn't mind going to the next slide, please. So as mentioned, at a very high level, CHIA is charged with objectively measuring and reporting on the performance of our healthcare system here. On things like costs, most notably performance against the state's cost growth benchmark, as well as quality, utilization, affordability, among other trends. Next slide. So CHIA's work derives from a number of different data set assets, including claims data in our all-payer claims database, hospital encounter data, survey data, provider cost reports, among others. Next slide. So each year, CHIA issues an annual report on the performance of the healthcare system, which includes top-line spending trends, as well as breakdowns by insurance markets and by service lines. So prior to diving into the pharmacy trends, I wanted to provide a brief recap of findings from our latest annual report to put some of the pharmacy trends into a greater context. Next slide. So this year's report focuses on the growth from 2021 to 2022, a period following, as we all know, 2 years of unprecedented volatility in our healthcare system. So while the findings should be viewed in this context, the report reveals persistent, longstanding trends, many of which predated the COVID-19 pandemic. So in 2022, total healthcare expenditures, or THCE as we call it, increased to $71.7 billion, with a per capita growth rate of 5.8%, above the healthcare cost growth benchmark. So apart from 2021, which was in many ways anomalous due to the pronounced rebounding of utilization, this 5.8% growth rate represents the highest one-year growth trend since measurement began in 2012. Next slide, please. So breaking down the THCE into service categories to identify drivers of overall THCE growth, pharmacy spending, as we see here, gross of rebates, increased the fastest among claims-based categories, growing to become the largest service category of spending at $13.6 billion. Pharmacy spending, I would also note, is unique in that when spending for other service categories fluctuated during the pandemic, declining in 2020 and rebounding in 2021, gross pharmacy spending did not follow the same pattern, but instead increased consistently in both years, 8.8% and 11.1% respectively. Next slide, please. So this slide focuses on the contributors or drivers behind the 5.8% increase. So of the $3.3 billion increase that we saw between 21 and 22, we see here that pharmacy spending, both gross and net of rebates, was the largest contributor of this increase. So over $1 billion gross of rebates, an increase of $1 billion gross of rebates. And even when accounting for rebates, pharmacy increased nearly $800 million in 2022. Next slide, please. And so finally, this slide looks at rebate trends and their estimated impact on total spending. So pharmacy rebates, which received and reported by payers, have been increasing year over year, which reduces gross pharmacy spending by $3.5 billion in 2022. We know that prescription drug rebates are most common for brand name drugs, constituting approximately 75% of total rebates reported by payers, with the remaining being for drugs deemed specialty drugs, a subset of brand drugs that treat specialty diseases and are dispensed at specialty pharmacies. So we see here that prescription drug rebate growth has slightly lowered net of rebates prescription drugs spending growth. We see the 8.8% gross to 8.3 as compared to the 8.3% when looking at net of rebate spending. But even net of prescription drug rebates, pharmacy spending continues to be a significant driver of overall costs. I think yes, there's complexity to in the accounting of how to capture both gross and net and the impact of rebates on the system. But I think the key takeaway here is that regardless of how you count it, including gross or including sort of gross of rebates, or if you exclude the rebate spending, the key takeaway here is that regardless of how you cut it, pharmacy spending is and remains the largest cost driver in our system. So with that, I'll turn it over to Molly, who will go through the specific pharmacy trends that we're seeing in our most recent report. Molly, do you want to take it away?
Yeah, thanks, Lauren. So one thing about the annual report data is we collect it at a very aggregate level. So as like the level that Lauren presented it is largely the level that we get it from all the payers and data submitters. So this does not allow for any insight into the drivers of the trend. So what's driving the prescription drug trend? So to provide further insight, we published an analysis on commercial prescription drug use and spending to really look under the hood of those large drivers from over the past 5 years. So first, on the next slide, we're going to take a step back and look at the prescription drug market, the various players and its complexities. So this graphic shows the flow of drugs, which is shown by the gray arrows, the flow of payments, such as premiums and copays, shown by the green arrows, and rebates through the market, shown by the blue. So this graphic really highlights the complicated dynamics of the prescription drug market, which are also not unique to just Massachusetts. So the flow of multiple types of payments are complex and challenging to follow, with little insight into how drug prices are set, how rebates are negotiated, and where the intended savings from rebates flow. So prescription drug rebates happen behind the scenes. PBMs negotiate with pharmaceutical companies to lower the cost of medications through rebates. So when a patient fills a prescription for a medication that carries a rebate, the manufacturer remits the appropriate amount to the PBM, with a portion then shared with the patient's plan. So rebates are applied to the list prices of brand name medications, and pharmaceutical companies set their own list prices. And for brand name drugs under patent, pharma companies can set any price for those drugs. And then one important note before we jump into the key findings from the prescription drug report, although rebates are an important part of the prescription drug supply chain and lower pharmacy spending and costs, they are not reflected in GIA's prescription drug report. And this is due to the fact that we do not have rebate data in the all payers claim database or at the granular level of the drug, at the drug level. So quickly on the next slide, this shows what the commercial prescription drug use and spending report focuses on. So the report focuses on the transactions at the end of the supply chain or at the point of sale where medication is provisioned to the patient. So the report focuses on payments made by pharmacy benefit managers, also known as PBMs, and patients to pharmacies, and again, does not reflect rebates, manufacturer list prices, or net revenue for entities along the supply chain. It represents drugs covered under the prescription drug benefit, so mail order or retail drugs, and does not include those administered under the medical benefit, like any administered in the inpatient or outpatient setting. Additionally, the report focuses on the fully insured commercial pharmacy claims from the agency's all-payer claims database, the APCD, and we identified high volume and high cost drugs between 2018 to 2022. And the population represents approximately 1.4 million covered lives per year. So while the GIC members are not included in this specific analysis, we know these trends are widely pervasive across the various market segments. And then so GIA published an interactive dashboard and corresponding data set to provide a means to examine costs and utilization metrics of drugs with the highest total expenditures. And then on the next slide, we'll present some high-level findings and key takeaways. And then there's also a lot of information available on GIA's website for further analysis. So looking at the entire fully insured commercial population from 2018 to 2022, the number of prescriptions shown by the line in orange declined 25% over the 5-year period, while the average cost per prescription shown by the blue line increased 54%. So this decline in utilization was largely driven by a decline in fully insured commercial membership during this same period. However, the finding stands that there was more spending for fewer drugs and fewer patients. So this shows that the overall increase in gross prescription drug spending over the 5-year period was driven by an increase in the average cost per prescription rather than utilization. So on the next slide, we're going to look at findings by top therapeutic classes. So our report organizes drugs by their therapeutic class, or also known as categories, based on their pharmacological, chemical, or therapeutic characteristics. So brief overview, there are 32 therapeutic classes that we looked at. And here we're showing, and throughout the report, we show the top 10 therapeutic classes by total spending. Here we're looking at 2022. So just a reminder that total spending is a function of cost per prescription times the number of prescriptions. So the immunosuppressant therapeutic class was the top class by spending for all years of our report, so 2018 to 2022. So immunosuppressants halt immune system activity and are prescribed to those who have conditions with an overactive immune system or an immune system that attacks healthy cells. For example, Crohn's disease, ulcerative colitis, plaque psoriasis, and some well-known drugs in this class include Humira and Stelara. So additionally, not only was immunosuppressants the top therapeutic class by spending, it was also the largest driver of overall prescription drug costs each year. And then in 2021, we see that the therapeutic class serums, toxoids, and vaccines pop into the top 10 therapeutic classes. This is due to the COVID-19 vaccine, and then we see it stay into 2022.
Molly, sorry to interject. I see Chair Sullivan's hand up. Might be a good place to pause and take questions.
For sure.
Yeah, thank you. I appreciate that. This is a ton of data to process. So could you just go back to the slide before?
Yeah, absolutely.
Which is startling to me. I don't know how others are experiencing this. So I'm just curious. I know your data set is all data from Medicare, so all government payers in Massachusetts and all commercial payers. Do I have that right?
No, so in this analysis, we're only looking at the fully insured commercial market.
Within Massachusetts?
Within Massachusetts. Yep, this is limited to Massachusetts residents in the fully insured commercial market.
And is there any data that, because, you know, the plethora of generics and they're so inexpensive, and sometimes, you know, people choose to just pay it cash because their copay is higher than their cash spend, and so you wouldn't capture cash patients. Is there any way that that the growth in generics and people paying out of pocket instead of running it through their fully insured, because the, you know, the copay sometimes could be higher? Do you have any sense of that? Because this is a pretty big number, at least in my opinion.
Yeah, I mean, the APCD only collects those transactions because we get the data from the payers, so it only collects the transactions through payers and copays and the payer paid amounts. I do think just because of the stark increase and decrease, like I don't think it would really moderate the trends that much. I mean, 54% over a 5-year period and 25% is pretty drastic. But yeah, I don't think we have much. There's, Lauren, correct me if I'm wrong, but I don't think there's much insight into that.
No, the only thing that I would say, and maybe this is more of a question for you, Molly, is where we see immunosuppressants as sort of the top persistent driver from a therapeutic class standpoint. I'm not sure even if the brand, or sorry, even if the generic drugs, the price of those really are accessible to pay totally out of pocket. And so I think that where we are seeing the largest spending drivers, I would hedge to bet that many of these are drugs that would be sort of unaffordable purchasing, consistently purchasing out of pocket. And therefore, I don't know that we would see, even if we were able to capture the totally out of pocket numbers, I wouldn't expect it to alter the utilization decline trends.
Yeah. All right.
And just one thing to say from the GIC's perspective, and I believe this is, well, I suspect it's true beyond GIC's experience, that our plan design, Jim can correct me if I'm wrong, I believe I have this correct, that if a member is picking up a prescription and the negotiated price with the pharmacy is lower than the copay, that lower price is what the member pays rather than the copay. So I experienced this, for instance, for a prescription I'm on, do I pick up the drug, and because it's such a low price, I pay $3 and something cents to pick up the prescription. So that is true for the GIC, and I believe is true in many other areas.
Yeah. All right. Well, thanks. I see that we have 2 hands up. I also want to alert our viewers and listeners that Liz Shabbat, one of our commissioners, has joined previous to Lauren and Molly getting started. So welcome, Liz. Eileen, do you have your hand up and then down? Do you want to ask a question?
No, I do. I have several questions. Thank you, Madam Chair. And thank you, Lauren and Molly. This is great information. I just wanted a couple of clarifications. So when you say it's the fully insured, that doesn't include self-insured, right? Is that true?
Yep, that's true.
Okay. And is it fair to say that self-insured, because they tend to be larger, probably have like more generous benefits? So if anything, these numbers are fairly conservative. Is that right? Because I mean, I think that fully insured, at least in my experience, tend to be smaller businesses that tend to not have as generous benefits. You don't have to agree with that assumption, but this doesn't include the self-insured. Is that's correct, right? And I guess the other thing I just want to make sure I heard you correctly. These figures don't include drugs that are administered in an outpatient or inpatient setting, which my guess is a sizable number of drugs or doses, right? So, like, do you have any sense of the magnitude of how many drugs are administered in an inpatient or outpatient setting?
So like you're right, you're correct in that this analysis only looks at the retail and mail order pharmacy, so the prescription drug benefit. We have not looked into the medical drug trends much. This did come up a lot in our review period for the annual report. So new this year in our total medical expense collection. So what we use to calculate all the data that Lauren presented at the beginning, we are including breakouts to try to capture how much spending is for medical benefit drugs in the inpatient and outpatient spending. That's kind of going to be, again, at this aggregate level, which, if depending on those findings, depending on the further interest, we can kind of follow the same process and use the APCD to dive into what drugs are driving that utilization and so forth. So we're starting to collect that. We're going to be collecting that data at a high level this fall.
And then just one final question, if I may. So I'm curious if you kind of look at the demographics. I assume that in pharmaceuticals, like in healthcare in general, is kind of an 80-20 rule, right? People who are sicker or with chronic conditions tend to use more of the services. And I'm just wondering, as Massachusetts population ages, if this trend is going to spike even more. If you have any sense of the demographics of the users, I guess is the question.
We don't. We kept this at a high level to kind of see what's happening in the market, and again at the therapeutic class level, the drug level, but we haven't really tied it to. We have an overview of the number of members that we're capturing here. Like I said, like the 1.4 million a year, but we don't have any demographic information tied to them for this report.
Yeah, but I think it is a fair point, and something that we are interested in looking at, sort of layering on drug spending trends with sort of further downstream utilization trends. And I think that inherent in doing that analysis would be to look at individual patient demographics to understand yes, they may be spending or driving drug spending on one hand, but on the other hand, if it's preventing downstream utilization, that type of analysis, I think, is something that we're interested in expanding on in future years.
And if I could ask one more, Madam Chair, if that's okay. So the numbers you're presenting, this represents 1.4 million patients in your all claims database. Do you then estimate that out for the full Massachusetts population of 7 million, or this represents just those numbers? So the full spend could be like a magnitude of 3 or 4. Is that?
So I think,
you know what I'm asking?
I think that the spending trend numbers that we saw on the prior slides, the 13.6 billion represents sort of total commercial spending in 2022, which includes both self-funded and fully insured. I think that I think you could extrapolate some of the trends from this deep dive report in terms of utilization and price per prescription. You can extrapolate to some degree in the commercial space, although you did note some of the assumptions and potential caveats that self-insured, they may have richer benefits, which may impact some of these trends, but I don't know that we would go as far to extrapolate the utilization trends to the mass health and Medicare populations. So while we do see that the overall spending trends continue to go up, that 13.6 billion is sort of all in all markets spending, which is significant, particularly in that it has now surpassed hospital outpatient spending.
Yeah, we're gonna probably eat up all our time with questions. However, we'll take these 2 more questions from Anna and Bobby, and then we'll let you keep going, Molly. I also want to announce that our designee from ANF, Dana Sullivan, has joined, so welcome. So go ahead, Anna, ask your question, and then we'll go to Bobby, and then we'll let Molly keep talking. How's that sound?
Great. So I wanted to just add to thanks for letting me speak, and wanted to just add that I think when you think about the rest of the commercial market, if the self-insured employers are more likely to have more comprehensive coverage, then that would likely drive utilization, maybe like people would be more likely to use a few more prescriptions, but probably wouldn't change the cost per prescription because that's negotiated on the part of the PBMs and with the manufacturers and the plans, which is complicated. We heard that. I'll pause and actually just say how great this presentation is. Thank you. Thank you so much for these data. And then I guess that was my one question is like, you don't have any evidence about prices being different for the self-insured versus fully insured? Do you think they're paying probably roughly the same prices for the prescriptions?
We do know that for a lot of the self-insured, to the extent that they're using the TPAs are using, if they're using the same PBM, you could imagine that they're negotiating sort of across different books of business, the same or around the same price points. But Molly, any more granular insights?
No, we only looked at the fully insured market in this analysis, and the APCD is largely limited to just the fully insured market as well.
Yeah, that would be my assumption, that the negotiations would be across books of business, but thanks.
All right, and then go ahead, Bobby.
Thanks. I'm just curious what the impact of COVID, if during this period, if that sort of drove down the number of prescriptions, and maybe also increase the costs. I'm wondering what the if that was factored into this? Because
so
2 years of a 5-year period were,
mhm.
sort of while during COVID.
Yeah, so I think there's kind of two parts to that. One, we do fully capture the COVID-19 vaccines here. So you'll see kind of that decrease from 2020 to 2021 isn't as drastic as previous years. And that's due to the large increase, the millions of vaccines delivered in 2021. So on the next slide, you see that the serums, toxoids, and vaccines group jumps into the top 10 therapeutic classes by spending. That's really driven by the utilization of those COVID-19 vaccines. So in terms of the spending captured by COVID-19, we can pull an exact number of how much that contributed from the 2020 to 2022 through. But in terms of utilization, that's captured there in the number of prescriptions. And then one other thing that we looked at was during COVID, one of the initiatives was 90-day prescriptions. So would the average cost prescription and the number of prescriptions be impacted by, days supplied? So if we look at days supplied versus the number of prescriptions, the trends largely hold. They're moderated just slightly, but in terms of that initiative, it doesn't really change the overall findings.
Thank you.
All right, thanks, everyone, and thank you, Molly. Let's keep moving.
Cool. So if we want to jump to the drug level findings on the next slide. There we go. So here we're showing the top 3 drugs by total expenditures, which is the function of their cost and their number of prescriptions. And all top 3 drugs by total spending were immunosuppressants, with Humira, Stelara, and Trulicity at the top in 2022. In our dashboard, we show the top 20 drugs by spending for all the 5-year period, so from 2018 to 2022, and mostly all top drugs by spending were brand name drugs. So brand name drugs are more expensive than generic drugs, due in part to the fact that the companies hold a patent on these brand name drugs, which eliminates the option for a generic equivalent and market competition. So drugs are granted 20 years of patent protection. So this also includes the development and time to market, so not just the time on the market. And then when the patent expired, generic makers offer drugs at a reduced price to the brand equivalent. So in the table below, we're looking at the top drugs by number of prescriptions. So those with the greatest utilization. And these were lisinopril, atorvastatin calcium, and sertraline HCl. So the top 2 are cardiovascular agents that focus on high blood pressure, heart failure, high cholesterol. And then the third is an antidepressant. So that falls into our central nervous system therapeutic class. These drugs are all generic drugs. And most of the top drugs in the top drugs by number of prescriptions that we show in the dashboard, so those top 20 each year, are largely generic. The only time that we see brand name drugs creep into the list of the top 20 by number of prescriptions is for vaccines. So as mentioned, we see the COVID-19 vaccines in 2021 become the top drug by utilization. And in 2022, we see a flu vaccine jump into the top drugs by number of prescriptions. On the next slide, we're going to look at the impact to members. So when we look at the entire market, so across all therapeutic classes and drugs for the fully insured commercial market, payers paid on average $13 per member per month out of pocket in 2022. And this represents approximately 10% of spending on prescription drugs. So this is shown at the table at the bottom. So you'll see the total paid amount for 2022, the portion that the payer is largely responsible for, the average that the member is responsible for, and then the percentage that the member cost sharing makes up of the total paid amount. So this is largely, the cost sharing metrics are relatively consistent from 2018. So you'll see that it increased from $11 per member per month for member copays, deductibles, to $13. This is a 20% increase. And you'll see that a lot of the increase in total spending, the total paid amount, PMPM, that 44% increase is largely absorbed by the payers, which is then ultimately absorbed by the consumers later on. Okay, so and then, yep.
And that is, I'm sorry, go ahead.
No, go ahead. If you have a question, go
No,
for it.
I would, so we had, Molly, we had a presentation made by staff to the commission at our May meeting on out-of-pocket spend. And that conclusion that you drew there at the end is the same conclusion and trend that we see based on our data, that the rising overall burden of cost here falls largely on the plan, and the member is largely protected, although I will say a 20% increase in the member's PMPM out of pocket is still a notable one.
Exactly.
That's good context, Matt. Thanks for adding that in.
The Commissioner Edmonds has her hand up.
Do you mind going back to the slide that listed the drugs for a minute? Yeah, it's a question that has come up to me anecdotally. Several people have commented to me about the impact of one of the drugs that I see in the screen having negative effects on them, that they're allergic to it. And that's just anecdotal sharing of information. But it's made me wonder that given the work that you do at GIA, do you have any sense of the negative impacts of any of the prescriptions that you see, or is that something that is within your purview to take a look at? In other words, is this anecdotal sharing of information something that is just unique to me, or is it more widespread?
Mm-hmm. Unfortunately, our data does not include sort of the adverse events or reactions or the level of efficacy, because it's largely driven from the payers. Now, at a macro level, we may see if there is a drug that comes to market that where there's a large portion of members or patients taking the drug that have adverse reactions, you would ultimately likely see that sort of reflected in maybe perhaps a downstream and declining utilization, but that's all that's very much at a macro level, and we don't have data that looks specifically at the question that you're asking, unfortunately.
I will say to Commissioner Edmonds' question, the Health Policy Commission did an excellent presentation on prescription drugs and specifically some analysis of GLP-1s so I'm happy to share that with the commission after this meeting, but it's also, I know WTW has done some really interesting work in that space as well. So these are some of the things that we're evaluating as we think about how to come back to the commission with that broader prescription drug presentation in the fall.
That's good. Good questions. Let's keep moving. Thank you.
Perfect. And then if we want to jump to the next slide, here we go. So the cost per prescription of the drug ultimately impacts how much patients pay out of pocket for a prescription. So the out-of-pocket cost per prescription for the top drugs by spending in 2022, so again, the Humira, Stelara, and Trulicity, ranged from about $79 to $287 per prescription. However, if you look at the percentage of costs that these make up, it represents less than 10%, just due to the large average cost per prescription for these top three drugs by spending. And then on the bottom table, we look at the top drugs by the number of prescriptions. So again, those cardiovascular agents and the antidepressant. So the out-of-pocket costs for the top drugs by utilization were much lower due to the lower average cost per prescription, as these generics cost much less. So the out-of-pocket costs ranged from about $4 to $6 per prescription, but you'll see that this represents a larger portion of the total spending, of the total average cost per prescription. Are there any more questions? This is our last slide, and then on the next slide, we just have a link to our dashboard, and we also publish kind of an interactive web page that walks you through the high level market findings with some cool interactive graphs and kind of a higher narrative than what's found in the dashboard. So take any final questions.
Yeah, so thank you for that. If you could go back to the other slide. I just want to point out potentially that my question about generics potentially is at least directionally aligned with the top drugs by number of prescriptions. So, you know, Lipitor was a branded drug, now is generic. And, you know, I see here it's the number one cost for, or at least the number one prescription, but the cost is very low. And the patient out of pocket per prescription, you know, some plans, you know, I know there are rules that say that, you know, if the cash price is lower than the, you know, than the benefit design, that the pharmacy must charge the patient the cash price. However, there are other plan designs that aren't so directive. You know, people at pharmacies are busy. So I did want to just, you know, validate the thinking that, you know, while these drugs are very expensive and I am befuddled by how much Humira has gone up as an average cost prescription over the last 10 years. There's also a plethora of generics out there that also have value. So that's more balanced than potentially your data suggests. So appreciate the opportunity to have this insight that I just shared. And Bobby, you can share yours and question because I see your hand up.
Oh, I just wanted to thank Lauren and Molly for a terrific presentation. But I also wanted to mention, because, you know, I realize this does not include self-insured plans. And what I am hearing from a number of people is that, you know, the cost from the PBMs, the cost that the people are paying at CVS and at Caremark are exorbitant. And a lot of members, there are 10 in fact that have informed me, and granted that's a small number, but they are actually going to GoodRx or to Canada to get their medication because of the very high cost that's being charged. And a lot of these are considered out of, you know, depending on whatever plan people have, there a lot of people are just cannot afford the cost.
Yeah, cost is an issue. Yes, indeed, Bobby, you are correct. Anyone else? It was a little bit of a sobering report. Appreciate the data presented.
I have a question, Madam Chair, if you don't mind. So we talk about generic drugs presenting a very high value, which we, through our plan design, encourage. And I think it can be said surely, just even looking at the data on this slide, that that the costs are per prescription are notably less than the brand name drugs that we see above, and even when you would compare them to their brand name reference drug. Do you have, so that said, do you have data that suggests any erosion of the pricing advantage of generic drugs over time? I do recall reading somewhere some analysis that while the the big drivers of rising prescription drug costs continue to be on the brand name side, that there are increases in generic drug pricing, that even if they're modest, even if a statin for $11.06, if that's, let's say it's overpriced by $1, given the huge number of prescriptions for that drug, that can have a substantial impact in a plan sponsor's overall trend. So I guess my general question is, do you have any data, or is it on your horizon to evaluate any of the dynamics there on the generic drug side?
I mean, using the data in the report, we can see, like, as a whole, how much generic drug costs have increased. I'm trying to pull it up because I know we looked at this at one point, because we didn't think it was going to be such a finding. But yeah, I can't find it quickly. I'm happy to look at that for you. But I think when we looked at it, it was kind of stark. We were trying to see if, brand name drugs, the price increases greatly outweighed the price increases in generic. And I don't remember that I remember being surprised by that wasn't a finding.
Yeah.
So even though you're correct, even though that they cost much less, they're still increasing, by double digits in cost.
Yeah. Thank you.
Yep, we can follow up with that number so you can share with the rest of the commission.
Great, thank you. And if you can just go back briefly to slide, I think it was slide number 13, which for me is sort of like, this is really a big takeaway slide for me. And the fact that you see overall spending on prescription drug climbing steeply at a time when utilization of drugs is actually declining pretty substantially. The only conclusion, of course, is the conclusion that you draw on this slide, which is that it's the unit price of each of those drugs that is the real driver here. And I'm recalling some work that I don't know if it was CHIA or HPC has done in the past that looked at this on the medical side, where we've seen inpatient admissions over time dropping pretty significantly, yet the overall spend for inpatient admissions continues to climb, and it is the unit price of each of those services that is the primary driver. So that's the sort of takeaway I have here. And I will say, at the highest level, those are the dynamics in the marketplace that worry me the most. And though it's the unit price of these services ultimately that is presenting the cost challenges that the GIC and so many others face. Am I reading that all correct, Lauren, Molly?
Yep, yes, spot on.
Excellent.
Yeah.
This is fantastic work. Thank you so much for presenting. I don't know if there's other questions here, but this is a good table setter for us as we as a commission grapple with this and want to really understand it more, so that it can point us in the direction of strategies to tackle this. So it's extremely helpful to us, and it's the first of a few stops on this prescription drug train that we'll be having with the commission over the months to come.
All right, thanks.
Well,
Thanks.
thank you so much for the opportunity, and please don't hesitate to reach out if you have any questions, and we'll be in touch with the follow-up items.
That sounds great. Thank you. Nice work.
Thanks so much. Take care.
Thanks for joining us.
Bye-bye.
All right, Matt, let's keep our agenda going forward. I don't see any hands up, so let's hear.
Okay, terrific. Thank you, commissioners, for a great discussion and great questions. At this point, I will hand it over to Director of Operations Paul Murphy and Communications Director Paul is Senior Director of Operations, and Communications Director Leslie Montero to provide us with a detailed report on this year's annual enrollment.
Thank you, Matt, and good morning, Commissioners. Today I'll be reporting out some statistics and what happened during our annual enrollment, some activities, and some new features that we implemented prior to annual enrollment. So on this slide here, we just wanted to show the progression of our portal. The number of members that have registered since the launch in 2021. You can see that our member portal has grown over the past 4 years. We are now at 101,708 people registered online for our new member portal. Next slide.
Well, wait a minute. Does anyone want to say wow? That's great. That's, definitely, I know I'm excited about it. And from member engagement, I think this is terrific. So congratulations. Maybe it's just the times, but I know Paul and team, I know you've worked hard to get the message out. So it's working. And I'm very excited about it. So congrats. This is great. I can't wait to hear more.
Thank you. We're excited too. We know that it has grown, and I think it's around 67% of our new hires actually enroll in benefits through the member portal.
Oh. That's great. I have a quick question. Paul, it's terrific to see that. I'm curious. I know this is only like I'm assuming it applies only to those who are agencies that are online, right? So I'm curious, like what percent of subscribers, I guess, is that number, and what percent of online?
So, Commissioner Kaplan, if you want to go to the next slide, I can demonstrate all of our members. So the portal is available to every member that has GIC coverage, whether you're an active employee, retired, municipal teacher, surviving spouse. If we have a valid email address on file, then you have access to the member portal. So what this slide demonstrates is on the right-hand side, you'll see the legend for active employees, COBRA, deferred, retired, etc. And then the donut will demonstrate the number of members. So the blue being 79,754 of our active members are in the portal, and the next largest is the 18,143, which is our retired members. But all members have access to the portal, and we do communicate that throughout the year, and we see the uptick in the registrations every day. If you go to the next slide, please. What we wanted to do here is break out the 101,000 by agency type. And what I mean by agency type is GIC categorizes our agency types into 3 categories: online, offline, and municipal. What the online membership, they participate in the state payroll system. That is the largest online payroll system that the state has. It's about 84,000 members participate in that payroll system. The offline agencies, what that demonstrate is all of the quasi-independent agencies that come under the GIC. So for instance, you have our housing redevelopment authorities, your quasi-state agencies like Massport, MWRA. Those memberships maintain their own payroll system. They're not directly interfaced with GIC. And then the last category being municipal is our 54 municipal agencies that have come in through the municipal program. So this slide demonstrates the breakout between those 3 agencies and the membership type. Go to the next slide, please. This slide really kind of demonstrates from on the left-hand side, before we launched the portal in 2020, GIC issued couple of 100,000 benefit statements once a year, every year. It was a snapshot in time of the members' benefits, and we'd issue a statement to the member. So in 2020, members could contact us and make corrections or updates to their GIC benefits. So we collect the data in 3 ways. The first one being data bank. That's where members complete the forms directly and mail them to our scanning vendor, and then they're put into our CRM system, Salesforce. DocuSign is members can go to our website or through their agency, and they can submit electronic enrollment forms to GIC, and then the portal. So you'll see in 2020 where we didn't have the portal, members submitted over 10,000 either electronic or paper documents for us to correct their benefit statement. So in 2021, where we introduced the portal, we had some members take advantage of the portal and correct their benefits or make changes to their personal data. 2,134 members went in and updated their personal data with the launch of the portal in 2020. You'll see on the last side, 2024, members went in, and the way that people are now updating their benefits online is they're using the portal. So we've practically eliminated all of the paper coming in for the benefit statements, and people are going in throughout the year, updating their personal data in the portal. The 2023 spike probably has a lot to do with the uptick in the registration last year, where we had so many changes to the membership, where Harvard and Tufts merged together, and we had some changes to the plan names, etc. So many people went in and gave us their email address so that they could have access to the portal. So that's the uptick in the 2023, why the number was so large. We collected a lot of email addresses from the members. If you go to the next slide, this slide just breaks out the categories of what members are submitting through the portal. A change request is members that are updating their personal information, their name, middle initial, address, etc. Inquiries are people that either go into the portal and submit a question to GIC staff directly in the portal, or they go to our website and they submit what we call an online contact form. So members can submit two ways to GIC staff. New hire, annual enrollment activity, those are the people that went in and made a change during annual enrollment. Qualifying events being, marriage, birth, divorce, etc. The last three, the standalone beneficiary, long-term disability, and life insurance, what those do is members just want to go in and update maybe their beneficiary information, enroll or cancel their long-term disability, or enroll or cancel or update their optional life insurance. So this just gives you a breakout of the volume that comes into GIC for the changes, and we usually start tracking this on a plan year after the public listening sessions, where members go in and start looking at their benefits in anticipation for annual enrollment.
Yeah, this is great, Paul. I love this, and it says that people want to take charge of their information, and it's probably more accurate if they go in and put their, changes in rather than call in, have your team do it. And sometimes there's, errors or, not intentional. So, it's a nice way to see that people are taking hold of their information. It's really great. Hey, Jane has her hand up. If she can ask a quick question.
Sure.
Here, Paul?
I love the presentation, Paul. I'm just curious about any comments that you have as this affects retirees in the use of the portal and also in engagement.
Our retirees, it's a mix. The newer retirees that were registered for the portal as an active employee and just recently retired continue to go in and use the portal to update their membership. Some of our other retirees do want to submit enrollment applications to us, so that by all means they can submit the applications. We will process it as we have done in the past. But we are seeing a growing trend that retirees are going in and registering for the portal and using the benefit. So it's a mix. It's not a requirement that you use the portal. It's just another tool where people can go in and maintain their benefits. But we can still update their benefits if they want to send us paper or an enrollment application, by all means.
And I would say just a shout out to Mass Retirees as a partner of ours, to serve our retired members. They've been very helpful in promoting the use of the portal, and while we, as you'll see a little later on in the presentation, navigating the portal is a significant reason for members to reach out to us. Mass retirees also assist members, one-on-one to navigate all of their benefits, including the portal.
Thank you, Matt. If
Yeah.
you'll see at the top of this, the 31,286, if you go to the next slide. This is a busy slide, but this will give you an idea of the 32,000 change requests that come through the portal. The right-hand side breaks it out on the types of fields that members are updating. And the way to read some of these donut charts is that you start at the top. It's like a clock, 12 o'clock, number 7, and you go clockwise so that it'll match the legend on the right-hand side. That way you don't have to match the colors to what exactly it is. Just start at the top and read it as you were reading a clockwise. But this gives you an idea of the fields that are being updated by our members. This 32,000 record changes that have come in the past would have required staff to go in and manually update the members' benefits. These changes come directly from the portal into our eligibility system magic without any staff interaction needed. So this has saved staff a ton of processing time and allows us to concentrate more on the paper applications that come in for health plan changes, qualifying event, etc. But members are going in and updating their personal information, which is a huge help to the GIC staff.
One of the things too here, if I may, that I find notable is that if you look at the big slices of the pie or the donut, I suppose, towards the bottom in the dark blue, light blue, magenta, light magenta, and off to the green, those are mailing address. Actually, I think also the home address above as well. So having accurate information about where members reside is really important to us because it determines, at least in part, what plans they're eligible for. So the degree to which we have accurate information there helps us to make sure that they're in the right plans.
Yeah. No, that's important stuff.
And it's also information that we would send to our health partners and all our other vendors so that proper identification, booklets, etc. can be sent out to the member directly.
Yeah.
If you go to the next slide, please. This slide, what it does is it breaks out the three ways in which you can submit an application during our annual enrollment period. Email, the DocuSign being the electronic form submission, data bank meaning paper application, and the portal. So over the course of the annual enrollment period, you'll see the most popular way that members are making changes during annual enrollment is now through the member portal, where we started off with 3,871 in the beginning of annual enrollment, and we ended with 6,040 towards the end of annual enrollment. So it really demonstrates members going in and making their changes directly in the portal, which is huge for GIC staff because all of the annual enrollment changes go directly into our eligibility system.
Cool.
Next slide. What this slide demonstrates, the pie chart again, reading it clockwise, is this is the number of health plan changes that members went in and made in the portal. So they actually switch from one plan to another. I have a number later on in the presentation about the total number of plan switches, but this just demonstrates the number of changes that the member went in and made directly in the portal, and no staff interaction for GIC is needed. The change goes directly into our system and sent directly to the health plan. I see, Bobby, you have a question?
I don't really have a question, but I just want to say that these slides are just terrific, and kudos to you and your team because it's really, it speaks to the communication, right? That members have received, right? So that they know how to do it. They obviously prefer the portal. I mean, it's just it's terrific. I would have to say, so I just want to compliment you and your team for all the hard work that went into this, and the results are just outstanding. So thank you.
Thank you, Commissioner Kaplan. It's an agency-wide effort from top to bottom on how we communicate the portal with the listening sessions, et cetera, preparing for annual enrollment and all the messaging. So it is a big effort across the agency to get this ready for the members for our annual enrollment.
Yeah, and I would just the shout out to our colleagues at ANFIT as well, who are a big part of this project and continue to support us very well.
Next slide, please. This just demonstrates the highest daily login. So every day we have members going into the portal. We track the people going into the portal just for the numbers of members going in. But during annual enrollment, you'll see at the beginning of annual enrollment, we have over 10,000 members going in, looking at their benefits, going into the portal, reviewing their benefits. And towards the end of annual enrollment, you'll see the most people going in to make or submit their changes before the annual enrollment ends, which this year ended on May 1st.
And these aren't unique logins. These are just total logins.
Yes.
So people could log in like
Any.
on 4/3, look at what they have, and then log in to make their decision on 4/30.
Correct.
Yeah. Yeah. I like how the bookends, people get excited, but then they wait until almost the end.
Yes.
But not all.
The next slide, please. This is some new data that we're reporting this year. In January of this year, we implemented a new phone system called 5.9. This new phone system took 9 months of planning, discovery, meetings, testing, etc. But what this phone system does is it interacts with our Salesforce CRM system. So it's compatible to Salesforce, and it gives us a holistic picture of when a member calls. So prior to the phone system, we would track the enrollment applications, et cetera, coming in under the member's record. But now we also have all of the inquiries coming in, whether it be by phone, chat, or just reaching out to us by email. But now all of the phone interactions are stored on the member's record in the call recordings, etc. So this gives us a better insight when we're speaking to the member. What the system does is that when a member calls in and a GIC staff member answers the call, the actual member's record will pop up on the screen for the GIC staff. So there's no searching for the member anymore. They are actually directly in on the member's record. So it gives us a better look as to how we interact with our members, whether it be by enrollment, email, online forms, and now we have the phone system. You'll see here that since implementation through the end of May, GIC staff answered 47,736 calls. The most popular being during our annual enrollment, but it is a busy time once we start those listening sessions through the end of May for the GIC staff. I'd like to extend kudos to my staff for taking these 47,000 calls during this time frame. And if you go to the next slide, this just gives you a breakout versus inbound versus outbound, as you'll see that most people call into the GIC and that we have a small number of people that we have to reach out and call back. The system also has a holding queue, which is new under the phone system. So if a member chooses to stay online with us without leaving a message, they will go into a priority queue and they will sit in the queue and the member is automatically called back the next available operator. So that is something new, and we're happy with that because members can stay online and it becomes a priority if they want to stay on the system with us until we pick up the call. The next call. This is also new with the new phone system, is we can now actually categorize what the members are calling about for each phone call. So we call them chat dispositions. So members can call in and speak to a staff member, and at the end of the call, the GIC staff member can enter a code which will track what members are calling in for. So this is something we've never had before, but this also allows us to give insight as to what we need to communicate or what members are calling the most. On the calls, you'll see that the biggest one is health plans, benefit questions, with 6,451. Eligibility being our next popular category. And then our third one being Medicare, where we have 3,938. So this actually gives us an insight as to what members are calling about. Also, I'd like to point out in the middle of the graph, there's a language line. So GIC with our new phone system has also implemented a language line. So members that need assistance, interpreters are available by us reaching out to the state services, in which we can have someone come in on the call and interpret what the member is speaking or needs assistance. So that is something new we have also put in with the phone system. And, we've seen that we're seeing an uptick. This is probably in the month of April, the 3, but we now have that availability for members that need assistance or need an interpreter to speak to a GIC staff member. If you go to the next one, the chat feature. This is also new with the phone system. This will allow members to speak directly while they're in the portal to a GIC staff person. So while they're in the portal, they can submit a question regarding where to click, what to enroll, they have a question, or they need some help with navigation. So we've put this in with the new phone system. Since January, we've taken 2,328 chats from members directly in the portal asking for assistance. And again, the most popular being during the annual enrollment period.
Bobby,
Okay.
you have a question?
Yes, I just have a quick question, Paul, regarding the language line.
Yes.
Is that 3 lines you have for languages, or is it 3 different languages, or
it's individual members that have called in asking for assistance with the interpreter services. So we have one line in which members can call in, and we will reach out to an interpreter services directly while we're in the phone system, and we can interact with the member at that. So we had 3 members take advantage of it when we rolled it out since the implementation. It's only one line, but 3 members have taken advantage of it.
Okay, I see. So the interpreter services, like do you know how many languages they
I don't know
offer?
off the top of my head, but I can say, looking at the implementation, they have well over a dozen most
Different
frequent
languages.
popular languages that come in. So looking at the implementation, we know it was well over 12.
Thank you. It's amazing, these numbers are just amazing, between the 47,000 phone calls and the 2,300 plus chats. It's absolutely incredible data. Thank you very much.
Thank you, but I also have to thank my staff. There are days
And your
it's
staff,
a challenge.
I didn't mean to exclude them. Absolutely. It's your entire team, including ANFIG.
So the next slide, please. So this also, we have the ability now that with every chat, we can also track what members are chatting with us about. So as I said in the previous slide about the phone system, eligibility, health questions, and Medicare being the most popular, we find that with the chats, the most popular still seem to be the benefit questions, eligibility, but there's a new category here, is portal navigation, which is also the top 3. So members go into the portal, they're in the portal, and they just need some assistance on how to start an application, where to go, where to click, where are the resources, and how to go through the portal. So this allows us to chat with the member, but we just wanted to demonstrate that, the portal navigation is also something we do with the members when they're in the portal.
Yeah. Hey, I have a question. I have my hand up here, Paul.
Sure.
We have such a strong desire internally to engage the member, make sure we're delivering, terrific, wow, customer service. I'm seeing that here in the data you're presenting. And we also have, really solid, strong communications abilities. What about creating some sort of kind of like video, short ones, maybe post on LinkedIn demonstrating how to use the portal? Because if that's your number one reason for calling in, maybe people would be more apt to give it a try if they, had a video running on one screen and then they were actually going into the portal. And you'll maybe show us next year with more focus on it, potentially, I'm just throwing it out there, that you've got more than 150,000 users, because that's telling that your number one chat, people are on it, but they don't know how to use it, but they want to use it.
Yes, those are good questions,
Yeah,
Commissioner
just a
Sullivan.
thought.
But I don't want to go too much into communicate. Leslie's going to present after this on,
Okay.
but I will tell
All right.
you that part of the navigation we've done in the portal is that we have videos and user guides that we have built. There's well over a dozen user guides on how to switch your plan, add dependents, start a qualifying event. So as the portal grows, we are also adding user guides and videos once you're in the portal on how to walk a member through that. So
Perfect. You
yep.
guys already are on it. Perfect.
I just want to mention quickly too that this data is all new for this year. So we're just receiving it and definitely will take all of it into account when communicating about the portal going forward.
Yeah, it's awesome stuff. We're all excited. Thank you.
Next slide, please. This screen share is also a new functionality that we put in with our new phone system. What this does is, to your point, Commissioner Sullivan, is members can reach out to us in the portal, click on a button that's called recursive sharing. What it does is allows the member to share their screen with a GIC staff. So we can actually see where the member is in the portal and if they're having any difficulty or they're getting an error message. So we'll be able to walk the member through it. So this is new. We've had 1,723 members request a screen share in which GIC staff had to help members navigate or tell them how to go through the portal to start an application. So this is a nice tool, and it allows us to help the member and navigate. Sometimes it's difficult to see exactly and describe where a member would be, but this really helps the staff navigate the member as well. Next slide, please. Now going back to annual enrollment, this is our transfer in and transfer out slide that we share every year. In the lower right-hand corner, you will see that 4,647 members change plans during annual enrollment. So as I said before, 3,071 members actually did changes in the portal. So we've had a little over 1,600 members submit paper applications or electronic forms, but the bulk of the changes came through the portal. The biggest takeaway, and again, I'm not going to go over every single number, and you can take a look at this after. The way to read this chart is if you look on the left-hand side, you will see all of the health plans from top to bottom in blue. If you read across, you will see, so I'll take the first one, Harvard Pilgrim Access America. If you read all the way across, on the right-hand side, you'll see 45. That is the number of members that transferred into the plan during annual enrollment. So when you read across left to right, those are the transfers into the plan. And it demonstrates what plan the member transferred out. So Harvard Pilgrim Explorer at 14, Health New England at 4, MGB at 3, etc., all the way across. If you take the top of the chart and read down, you'll see Harvard Pilgrim Access America. In reading down, there are 25 members. The red numbers at the bottom demonstrate the number of people that transferred out of the plan during annual enrollment. So there's a lot of numbers, but just remember left to right is transfer in, top to bottom is transfers out. And that gives you the total applications that we processed. And the next slide. This is an annual enrollment change report. So when we take into consideration all of the people that come in during annual enrollment, pick benefits for the first time, any new hires that come in, and how many people have left the Commonwealth or canceled their coverage. So the left-hand side demonstrates the new members, the transfer to, which you'll see at the bottom, the 4,647, and then the total. On the right-hand side, it gives you members that have either terminated, canceled their coverage, etc., and then the transfer from the 4,647. The last column is really the net gain. This gives you the net gain loss for each of the health plans. So you'll see Harvard Pilgrim Access America at 55 and all the way down. You'll see that the most popular plans during annual enrollment will be the Plus plan at 898, the MGB at 598, and Community Choice at the 527. But this gives you a nice snapshot of the net gain by health plan during the annual enrollment. And the next slide. What we do every year is when all the processing is said and done, we'd like to give you a snapshot of our total membership by state and municipality. So this will give you the total numbers, individual family state, individual family municipality, and giving us a total of 418,659 members enrolled in health insurance with the GIC. And the next slide. This slide is new information that we'd like to present. And Commissioner Kaplan, I know that in the past you have asked about enrollment in the various products. So we thought we would share the enrollment for the last 3 years for all our other ancillary products. So you'll see the purple being the dental vision plan at 11,789 across. You'll see 12,033, 12,747. The yellow being long-term disability, blue being the optional life insurance, and the green being retiree dental. So you'll see over the past 3 years, these products have progressively increased in the membership, but we've never really given this information before. So we thought we'd share it so that, you have an insight not only to health insurance, but how the other products look over the course of 3 years. And this is the total membership in those products.
Oh, this is great. This is terrific. Thank you for that.
You're welcome. On the next slide, this slide represents the number of buyout applications, and the buyout is available, to refresh your memory, twice a year, in the spring and in the fall, where members that are enrolled in health insurance can cancel their coverage during annual enrollment or in the fall and buy out their application. So GIC will send that member 25% of the full cost premium, a check each month when they participate in the buyout for a period of 12 months. So we had a total of 129 members elect buyout, 90 of which members did it actually in the member portal.
That's good.
Flexible spending, this gives you a snapshot of the enrollment. Each year, members are required to enroll in the flexible spending account. So this gives you a snapshot that this year, 14,598 members enrolled in the healthcare spending account for a total of $29.2 million in total elections. And for the dependent care, we had 2,860 enroll in the dependent care for a total of 9.6 million in total annual elections.
A lot of numbers. Keep moving.
Paul, is that an increase in the flex spending? Do you know if that's an increase in both dependent care and the healthcare spending?
I'm going to have Cameron speak as the manager for those products. I think he has some numbers to share.
Oh,
Certainly, that's an increase of about 1,300 participants on the healthcare flex spending account compared to last year, an additional $4 million in elections for that plan, and then it's almost 1,000 more participants on the dependent care plan.
wow. Okay. Thank you.
And just one clarification, I just, one of my staff let me know that the language line has over 240 languages available and 16 are available immediately with translators. So it has 240 languages available to members.
Wow, it's impressive.
So that's the annual enrollment activity and statistics. Happy to take any other questions. Otherwise, I can turn it over to Leslie for the communication piece.
Yeah, I don't see any questions, Paul. This was great. You can tell by interest by commissioners. So keep up the good work.
Thank you.
So hello, Leslie. I was stealing your thunder, so I'm excited to hear about communications.
Hello, good morning, commissioners. So as we have done in previous years, our communications team worked closely on annual enrollment with various GIC departments, especially operations. And together we continue to streamline our annual enrollment preparations and processes as you have seen the result. This year, communications about annual enrollment included marketing dedicated to increase MyGIC link registration and usage numbers, helpful resources to help members prepare, like video tutorials on how to view and update their GIC benefits, compare health plans, as well as benefit guides, and information about Unicare changing its name to WellPoint, of course. This slide demonstrates a list of these communications and depicts which ones have information promoting MyGIC link registration and usage, and you can see that in the teal. As usual, the first of many annual enrollment communications is the annual benefit statements, which continue to be sent earlier than in previous years. We continue to send out benefit statements by print mail to GIC retiree members not registered for MyGIC link, and an email to all GIC members encouraging them to register or log into MyGIC link to view their GIC benefits and personal information, since they already have access to their information 24/7 this way. Both initial communications, among other annual enrollment communications, while encouraging GIC members to review their benefits, also encourage them to review resources from each carrier in order to make informed decisions and provide members with instructions for ensuring that their personal information and other information really is accurate in time for annual enrollment. The GIC benefit guides were also sent via print mail to GIC retiree members and agencies and continue to be made available on our website to all of our members earlier than in previous years. We were also able to streamline last year's benefit guides by reducing pages on the municipal and RMT guides, so the retired municipal teacher guides. And of course, by combining the GIC state employee and state retiree and survivor benefit guides for the very first time. This improvement was made with employees who are transitioning from active employment into retirement in mind. We also continue to take on more previously outsourced work by creating the design, formatting, and content of the benefit guides in-house. And of course, this results in an overall decrease in communications costs and coordination efforts. And now on the next slide, we can see GIC website stats during this year's annual enrollment period in comparison to previous years. As expected, we can see a large spike in last year's numbers due to the many changes that occurred as a result of the various procurements that took place for GIC benefits effective July 1st of last year. Here we can also see that even though numbers have gone down as expected in comparison to last year, a procurement year that typically happens every 5 years, this year's numbers have increased overall in comparison to a non-procurement plan year, which in this case, we're comparing from FY 2022 to FY 2024. We can also see that the benefit guide views are the exception to this because we did not see a decrease as compared to last year. And we actually saw an increase of approximately 5,000 extra views this year. We hypothesize that this is because the benefit guides serve as the #1 resource for members during annual enrollment and have proven to be a helpful tool for our members. And finally, on this slide, we can see GIC social media engagement stats during this year's annual enrollment period. One item to highlight is our YouTube channel, which continues to grow in subscribers and engagement, especially during annual enrollment. Viewers on the channel are spending approximately 9 minutes on a video before leaving, which in this fast-paced world, as you might know, is pretty impressive. And this lets us know that our content is engaging. We continue to leverage our social channels to help reach all of our members with important information to assist them in making informed decisions about their coverage. And this includes partnering with various agencies and our carriers to help reach as many of our members as possible. And just a final note, overall, we look forward to continuing to explore more avenues, engaging with our members, as well as growing our MyGIC link registrations and usage number. As Paul mentioned earlier, we have a lot of new data to work with, so we're definitely going to be leveraging that to make tailored communications to our members. And as usual, we're also going to be starting next year's annual enrollment planning earlier this year. Thank you.
Yeah, really well done. Quick question, Paul and team. Do we ever anticipate going back to having in-person health fairs?
I guess I'll leave that one to Matt.
Well, do we think our members miss them because they get so much more engagement?
Yeah, so I would say certainly the data, when we look at it about the level of engagement with our members through the virtual sessions, is many, many multiples higher than the engagement, the number of people who would attend in-person meetings in the past. I will say that the in-person meetings are a tremendous amount of work at a time when we are very busy with all the other elements of our annual enrollment. So I think we have to take all of those factors into account. So that's what I would say about in-person elements, but happy to hear from others.
So I just want to make a comment, which is I think that no one really misses the in-person because it was very difficult for employees to get away. No one had, people had to use their own time to come to the sessions. And if you didn't work at Ashburton, it was even more difficult. So this is much better. I hear a lot of people are really much more engaged than they would have been and are receiving information the way they like to receive it, right? So they can ask questions and that directly pertain to them or their specific, situation. And I don't think the in-person meetings are really missed at all. Or the fairs, I should say, not meetings, the health fairs. Yeah. And I think it's the same even with the listening sessions, because it wasn't always easy for people to attend.
Yeah. Well, technology has evolved the GIC, and that's just really terrific, and it's really well done to staff and important because we're engaging more members on their own time where they want it, and we're reducing workload. So that seems, or maybe shifting workload, and that seems like a really good thing. So very exciting to see that, and appreciate the work that it took to get there, because change is never easy.
And Commissioner Sullivan, if I could just add two things. When we were building the member portal, we took into consideration what is the most frequent questions that members ask at a health fair. The two questions were, how do I change my health plan? And what happens when I turn 65? So in the member portal, we have actually put videos and walkthroughs on membership. And you can see on the health plan changes, most people are submitting them now through the portal. So that was two big topics that we wanted to build in the portal to help the members.
Yeah. Well, it sounds like you really took a lot of attention to detail in the transition, Paul, with your team, and that makes a huge difference too. So very cool.
I can just, at the tail end here, make a couple of quick comments before we move on. We're pretty much on schedule here, but just two observations. One, I think it's fairly obvious. We've, through the use of the portal, really engaged in a major shift to self-service for our members, which of course is what we all expect to conduct a lot of pieces of business in our lives. You can do it for flights, you can do it for paying your bills, you can do it for your banking, and here you can do it now through the GIC. It does still mean that, this year, as you can see, and I suspect for a period of time going forward, it's going to take some time for our members to get acclimated to it. As Paul noted, it's the single biggest reason why members will send us a direct message when they're in the middle of using the portal. So that's going to take some time to get them kind of essentially trained and acclimated to using the tool. Secondly, I just want to acknowledge here that the capabilities that we have at the GIC really now rival what you would find in the member services unit of many private sector companies, including our health plans. That is intentional, and it's the result of work here at the GIC that predated my arrival, as you all know. And we built this. We designed this, and we built this as a GIC team, an ANFIT team, with the assistance of contracted experts, but we did not simply contract with an outside plan to adopt something off the shelf. This is something that this team designed and built with the advice and guidance of a vendor. So I think that's notable here. And I would say, as I think is implicit in all that we do, and you all know this, but we don't contract out our call center to a private company. These are calls and messages that are received and taken by state employees. In many cases, staff who have been with us at the GIC for many years. So we think, I know that we get a great deal of value from that. These are people who have been interacting with our members for many years. They have knowledge and expertise that is specific to the GIC that comes along with that. So that has been a really important element of how we've approached this project, and something about which I'm quite proud. So just want to note that at the end.
Yeah, thank you, Matt. All right, let's move on. Congrats again, and thanks for sharing all this.
Great. Thank you all, commissioners. At this point, we will move on to the next agenda item that will include a vote. So I'll turn it over to Cameron McBean, our Director of Vendor Management, who will present our recommendation for dental and vision benefits consultant. It's a consultant to guide that procurement. Cameron?
Thank you, Matt, and thank you, commissioners. If we could move on to the next slide, please. Just as a bit of background, the new plan year that's about to begin July 1st is the last year of our 5-year dental and vision contract cycle, which means we will need to take those products out for procurement beginning this summer and working through the fall so that we can have a final recommendation with rates to present in December. As a result, we conducted the procurement, and we are going to be recommending that the commission move forward with the proposal from Lockton Companies. They are headed up by Patrick Harridan, who was formerly a GIC consultant with Arthur J. Gallagher. Do want to acknowledge that unfortunately we did only receive the one bid. It was a surprise that our incumbent elected not to supply a bid. And we think that may have had some impact, but we will be conducting a post-mortem to evaluate why we didn't receive more bidders. Just want to reassure the commission, however, Lockton is a very, very large brokerage and consultancy firm. We're comfortable with the resources they can bring to bear to support the GIC, and we're comfortable working with Patrick Harridan as well. So before we move on to the vote, happy to open the floor up to any questions that the commission may have.
I don't see any questions.
I have a question.
I have a question.
Go ahead, Bobby.
Vice Chair
I have a
Kaplan.
question, Cameron, which is
Yes.
regarding the scoring, which I know we haven't looked at that slide yet, but and it doesn't really give us an option because there is only one bidder. But I was very curious about the SDP program,
Yes.
the scoring, the rating, I should say, which is pretty low.
Yep.
And how that would compare if we had another bidder, which we did not. So I'm curious what Lockton is, what's the reason for that, and what do they plan to do about it, if anything?
Oh, they committed to 1% of SDP scoring, and just a reminder that the supplier diversity weighting as 25% of the bidder's total score, that is a state mandate. And given the relatively limited pool of vendors that we typically work with, whether insurance carriers or consultants, we try to come up with a fair rating system in advance. I'm happy to provide the additional background that didn't appear in the recommendation memo as to how those different scores were applied. But the 1% that Lockton committed to is frankly not unusual for most of our vendors. A 3% or higher score would be unusually high based on most of the SDP commitments that we typically see.
And
we know that there are rules around confidentiality on bidding. So appreciate the color that you provided, Cameron.
Yeah.
I don't see any other. Oh, here we go. Toby.
Yes.
Nice to hear from you, Toby. How are you?
Good morning, Cameron. From a qualitative perspective, how would you compare Lockton to the incumbent?
Well, this is actually going to give us a new perspective. Boston Benefit Partners has been the incumbent for a number of contract cycles extending well before my tenure with the GIC. And our suspicion, frankly, is that they had been the incumbent the incumbent consultant for these products for so long. I think a lot of people in the local market who typically bid on GIC business were inclined not to bother for that reason. In fact, when I reached out to Lockton to let them know that they're the apparent successful bidder, they were surprised and expected that Boston Benefit Partners would be likely to renew the contract as well.
Huh. All right, thanks for that.
But we don't have any concerns with Lockton's capabilities to support us in this procurement.
Thank you.
And Patrick Harridan is well known in the local sort of broker consultant community. He's very familiar with the GIC. He's an individual with whom we've had regular communication, as we do with a number of other kind of municipal consultants.
Yeah. Yes, indeed. His name sounds familiar.
Okay.
Right, oh, go ahead.
Sorry, I was just going to say, if we don't have any other questions, I think we can move on to the next slide.
Thanks, Cameron. So at this point, since we've had discussion and we're ready to take a vote. I will request approval on a motion or entertain a motion to authorize the GIC to contract with Lockton as the apparent successful bidder for dental and vision consulting as recommended by the procurement team. So do I have a motion?
So moved.
By Bobby, second?
A second, please.
That sounded like Liz, so thanks to both of you. So at this point, Andrew, you'll assist me in taking roll call. I am a aye.
Thank you, Madam Chair. Vice Chair Kaplan,
Aye.
Designee Sullivan,
Aye.
Designee Butler,
Aye.
Commissioner Shabbat,
Aye.
Commissioner Choate,
Aye.
Commissioner Davis,
Aye.
Commissioner Edmonds,
Aye.
Commissioner Gentile,
Aye.
Commissioner Guerin. I'll come back. Commissioner McEnany,
Aye.
Commissioner Murphy Rodriguez,
Aye.
Commissioner Silva,
Yes.
Commissioner Sinenko,
Aye.
and Commissioner Sullivan.
Yes.
The vote passes unanimously.
Thank you. Thank you all. Good work here. Go forth and contract in good faith and in good financial terms for us, as you always do.
While you've brought that up, let me just note that you'll be receiving the contract for signature electronically within a few weeks. So I ask that everybody please attend to it when it hits your in mailboxes. Thank you.
Yes, thank you, Andrew. All right, I think at this point, if there's any additional business.
We do have one final piece of business, Madam Chair, which is the CFO report, and turn it over to Jim. Jim Rust, our CFO.
Thanks, Matt. I'll be brief. But before I start on the end of the year budget, I want to mention in terms of supply diversity, I heard a question, and just generally, I didn't want to interrupt Cameron for this on that about the specific procurement. But we work closely with the supply diversity office here within A&F, who's doing tremendous work trying to broaden the breadth of folks that will respond to bids on anything across the state. So we work with them a lot. We get reporting from them on how the GIC is doing, and we do meet and exceed our benchmarks on a yearly basis. So I just wanted to, I don't think we've mentioned that much at the commission, but there is a whole effort within the state to increase the supply diversity. We're taking part vigorously in that.
Yeah.
Now,
I think,
sorry,
Jim, that's a great topic. I know the meetings are always so busy, but potentially a few words in the executive director's report, on how the GIC looks. If you're tracking that data, I think it would be great to see, because, at least I know I'd love to see growth in that diversity and, how the state is helping support that and the GIC specifically. So good.
Oh, it's a great idea, and they do provide a lot of reporting now. So we'll start packaging that up and putting it into some of these other updates that we do around spending and whatnot. And with that, I will jump, since we're almost out of time, to the last slide, if you don't mind here, and just get to the bottom line. I think folks at this point are used to the graphs, and if you want to look at where we deviated over the course of the months and the payments to the vendors, you can see them. But since we had a tight budget year this year, I wanted to give you an update in June before we adjourn for the summer. In September, we'll be back to let you know how we did. But as of now, we are pretty much right on budget, 0.3%, $8 million. That is well within the range of weekly volatility for us, as you know. We expect to land the budget and right on budget. So I would expect this number to be pretty close to zero when I come back to you in September for an update. We do have enough funds to get through the year, so I'm not alarmed. But from where we've been in the past few years, as folks know, we generally run a little bit of a surplus. This year, we're coming right on. This wasn't unexpected
as you know, from the last few months when I presented, this is where we expect it to be. So, so that's just the update for June. So the commission knows where we're at, that we are funded sufficiently for this year. We do expect that next year we also will have sufficient funding, but again, there's a lot of factors out of our control, and we'll keep you updated on those. And I'm happy to answer any questions.
All right. I don't see any. Looks like another year, keeping us good, Jim, financially. So thank you.
Thank you.
Yeah, and I do just want to acknowledge Jim and all the work that he and his team do to land at this result. This doesn't just happen by accident. Though, as Jim noted, a lot of factors are out of our control. There's still a tremendous amount of work that he and his team put in to get us to this point. So just want to thank and acknowledge Jim.
I have a quick question, which is regarding the dental and vision benefits. I'm just sort of curious, if you have an idea what was, sort of what's causing
Sure. Yeah, I do skip mentioning that. I mentioned at the beginning of the year, but I don't expect people to remember that. So that's a good question. That we expect. We have this forecast right off the bat. It's enrollment. So dental is 100% enrollment. So there are more people enrolling, and they are enrolling in the more expensive plan. And this has been a steady item for decades, like predating my time here. And we have looked at it. Tried to look at it with HRD and whatnot to see if there's been more hiring, or we've talked with our consultant about whether our plan is richer than other plans, and neither of those answers would drive this kind of change. So we're just basically going to up our forecasting to expect more enrollment. So next year, I think we'll be on target with this. But it is totally number of people enrolled. There's more people enrolling in the plan. Maybe people are taking their dental health more seriously. It's a little bit of a mystery, but we're happy people are taking advantage of the benefit, right? They should take care of them, but we have adjusted our forecasting assumptions accordingly to try to not miss on this. ANF will be providing funding for this deficit. It'll be in a supplemental budget at the end of the year, so this will be taken care of.
Right,
but thank you for pointing that out. It's been a while since I talked about it.
Thanks, Jim. We appreciate it.
It's a good little benefit. People are taking advantage of it. Takes a while to figure it out, but they're figuring it out, right?
I think so.
Yeah. All right, good work. What do we got next? I think we're at time, but if there's any other business we should bring up before we get together in September, now is the time. I don't see any. Bobby, before I miss your hand up.
No.
Good.
No,
All right.
Yeah.
All right,
Thank
everyone.
you.
Well, at this point, I will entertain a motion to adjourn.
Motion to adjourn.
Second.
Second.
So all in favor, verbally say yes.
Aye.
Yes.
Aye.
Have a great
Right.
summer, everyone.
Have a wonderful summer. Did you
Bye.
get all those ayes, Andrew?
And I assume there's no no's.
Yes.
I did.
All right. Enjoy I guess it's hot for some people, but enjoy the sunshine, and we'll see you in September. Bye, everyone.
Thank you all.
Bye.
Thank
Bye.
you.